طيب الله يعطيكم العافية. بسم الله الرحمن الرحيم. الصلاة والسلام على رسول الله. Today lectures will be about a very tricky subject in our neonatal intensive care unit. It's a subject that we talk about a lot. We see it frequently. We like to think that we know how to treat it. In the end of the day, unfortunately, we are just providing some kind of support care to these kind of cases. There is no cure, like a specific treatment and curative approach for this problem. And even worse on that, over like 60 years of how old is our NICU medicine or neonatal medicine, up till now, we have not reached like a definitive way of preventing these serious medical problem from happening. This is just where I'm practicing right now, the King Abdullah Specialized Children's Hospital in Riyadh. So in general, today we're gonna talk briefly about the epidemiology of neck. We are gonna summarize the known risk factor of necrotizing enterocolitis. We're gonna review the pathophysiologic basis of necrotizing enterocolitis or what's known about it. And then we're gonna go over some suggestive strategies to prevent neck from happening. I'm not gonna actually go over presentation or treatment of neck in this lecture. That's not the objective of this lecture. That will be a separate lecture that we can plan in near future to talk about if preferred. I'm gonna actually talk in English for most of the lecture. I'm not sure what everyone feels about that, but I think from time to time it's good to have an English lectures in full. And then probably the discussion in the end, we'll do it in mixed Arabic and English, inshallah. So in general, in US, the incidence of neck range from 3 to 9%, depends on the center that they are reporting. On average, it's 7 to 8%. In Canada, it's around 6%. In Japan, it's really low. What they're reporting is 1 to 2%. In Saudi, there is conflicted data on the incidence because the data is a little bit scattered and not that well documented. But in general, from what I found, it's between 4% and 16% based on what published. 90% of these problems happen in premature babies. So we know that it is a disease of prematurity. We all know that the age of incidence correlate inversely with the gestational age. In a sense, the younger you are at birth, you mean lower gestational age, the later it takes for you to present with neck. And that's why in term baby, usually we see the neck in the first week of life. In extreme low birth weight baby, like a 25, 24 weeker, we see it around 6 to 10 weeks of age. The race seems to have a role in the incidence. We know that in general, African-American is, in America, for example, is more, or dark skin color babies is more frequent to have it compared to white. Genetics also is a hot topic in this problem. There's a lot of ongoing studies right now trying to sort out any kind of genetics background for those babies who develop neck comparing to those who don't develop neck. The pathophysiology, as I said briefly in the introduction, it's still not well defined. We don't really know what cause necrotizing enterocolitis for sure. There's a multifactorial theory, as you hear from different people and presenters. In general, the main factor, as I mentioned, it's the prematurity and low birth weight, as documented in many reports and publications. Formula feeding have a role. When we compare babies who are fed formula to those who are fed breast milk, we found that formula or cow-based milk might increase actually the rate or the incidence of NEC by 300 times, meaning 2.8 fold. That based on the recent Cochrane review. Congenital heart defect also have a role in specific in-term baby. However, in a few studies, like in Fisher study, they found that actually extreme low birth weight babies who had congenital heart defect will have 5% increase in the rate of NEC. They reported in their study 13% of babies have NEC, comparing to 9% in their study with babies who don't have congenital heart defect develop NEC. Also, Olison in 2015 reported on the treatment of PDA in extreme low birth weight and the role of that, or the association of that with NEC. It's not a causative effect kind of study. They found that treating PDA with ibuprofen actually is associated with 50% reduction in the incidence of NEC. However, treating PDA with Indocin or NSAID, in specific the intomidacine, will increase the rate of NEC by almost like 2 to 3 folds. So there is some kind of association, but that's again, the studies were not powered to study this kind of issue. So definitely we need more data on this issue. Blood transfusion, there is conflicted data on the association between blood transfusion and the development of NEC. We will talk more about that in later in this study, in this lecture. But briefly, most of the reported cases on the association between blood transfusion and NEC is retrospective reported cases. However, a couple of randomized studies did not show association between blood transfusion, and we'll talk more about that later on. Infectious agent, it had been reported in few studies that NEC might come as an outbreak in the unit, meaning all of a sudden you will have few babies of NEC, and then it will go away for a few months, and then it will come back with a cluster of NEC cases. From that standpoint, they assume that might be some kind of association between viral enteritis or another infectious pathophysiology behind this cluster of episodes. If you guys have any questions, please interrupt me anytime and ask your question. So to talk more about the mechanisms behind what we know about NEC and its pathophysiology, we'll go through briefly through these 6 topics. First, when it comes to prematurity, as I said, we all know NEC is the disease of prematurity. There's many studies on that, like the Fitzgibbons-Bigons in 2009. It's clearly shown here that NEC is associated with gestational age. The youngest you are, 23 weeker, the rate is 10% in this study. 30-31, it goes down to like 3%. In almost 34 weeks, it goes down to less than 1% of babies. So it's clearly there's association, inversal association between gestational age and NEC. Also the weight, the smaller you are at birth, regardless of your gestational age, actually associate with higher rate of NEC as well. Again, ranging from almost 10% in those less than 500 grams to less than 1% in those more than 2 kilos. Autoregulation of microcirculation. We all know that, when a premature is born, every organ is premature, including the bowel. What we mean by microcirculation is actually the adaptation of the circulation of blood to the bowel when it comes to a sudden change in their physiology, whether that is feeding the baby or giving a blood transfusion and change the viscosity of the blood, severe anemia, and then giving blood and causing what we call pre-perfusion, possible injury, and the slow microcirculation adaptation for any kind of sudden change in the physiology of the bowel. So we assume that it has a main role in the development of neck in premature babies. We all know that the immune system is, again, one of the systems that is premature as well, and it's deficient, whether it comes to secretory immunoglobulin A response to infectious agents, whether it's the neutrophil function or macrophage activation function or cytokine production. All of that is deficient and is different when we compare premature babies to term baby, and that might have a role in development of neck. When it comes to the anatomy and the physiologic changes in the premature baby, we know that Baneth cells, which has a very important role in protecting the intestinal epithelium against the bacterial invasion, it's much less in numbers in premature babies compared to term babies, and actually the number will goes up with the gestational age. Also, when it comes to the goblet cells, which secrete the mucus or the mucin, which also has a very important role to create a mucus layer, which is very important to the growth of the bowel and to mature the bowel as well, and to enrich the bowel with the beneficial flora, whether it's lactobacillus or Clostridium or other beneficial bacteria. Also, the function of the goblet cells is deficient in premature babies, and it actually increased by the gestational age as well, and that might play a role for the development of neck in premature babies. Very important topic, which is the intestinal dysbiosis. We all know that the gut colonization of premature baby and term baby is affected by multiple factors. Whether you are born preterm or not, that have a very important role in the development of these flora. The mode of delivery, whether it's vaginal or more kind of aseptic kind of delivery like C-section, has an important role in, again, introducing the bacteria to the baby during the delivery. Are we feeding the baby breast milk or formula has an important role. We all know that the breast milk will introduce the beneficial kind of bacteria to the baby through sucking the milk from the breast of the mom, which most likely is contaminated with the flora of the oral of the mom, as we found in a couple of studies when they compared the flora from the maternal oral cavity and placenta to those babies' flora development. By the way, the idea that the fetus is living in a sterile environment in uterus, it's not valid anymore. This theory is not valid anymore. We have enough study now to support the growth of bacteria from the fetus, from the placenta, from the amniotic fluid. So we know that actually the baby does not live in, the fetus does not live in a sterile environment. And these bacteria, the growth of these bacteria is actually affected by, as I just mentioned, the flora of the maternal oral cavity and what's in the vagina, etc. So that also has just like it's off note to mention. Now, normally this microbiome shift from bacilli to gamma proteobacteria, which is gram-negative mainly, and then to Clostridia over the time after birth. It goes from week to almost 6 weeks of age where this shift develop. If we interrupt this shift, that's when we cause a problem, and that's when we cause the dysbiosis of the flora and might have a role in the development of NEC. The main factor that might modify these normal gut colonization pathway is using antibiotics, or the excess use of antibiotics in babies, whether it's prophylactic antibiotics at birth or rule out sepsis because of any problems, and then prolonged treatment for what we call culture negative infection and this and that. So use of the antibiotics will modify and will shift the microbiome from beneficial microbiome to pathogenic microbiome, and that might have a very important role in the development of NEC. Now, when we study the stool microbiome of these preterm baby who develop NEC, we see a clear increase in the gram-negative and a clear decrease in the Firmicutes bacteria, which is the Lactobacillus, the Clostridium, the beneficial one, and the bacteroides in a few days before the development of the NEC. So that's a clear evidence that, again, dysbiosis might play a role in the development of NEC. So this is just a diagram to summarize the factors that actually affect the microbiome and cause the dysbiosis, whether it's a blood transfusion and cause anemia, change in the vascular perfusion, as we mentioned, the antibiotics use and the change in the flora, the length of duration of treatment, using of anti-reflux medicine, especially the anti-acid medicine, feeding, whether it's formula or milk, how we feed the baby, what we are feeding the baby, the use of probiotics. All of these factors has an effect on microbiome. We will come across all of these factors actually during this lecture as well. Okay, moving on to blood transfusion. We all know that it's kind of a hot topic now to talk about transfusion-associated gut injury, the TRAGI, or the blood transfusion-associated NEC, etc. The theory behind it is multifactorial as well. People who think there is an association, they believe, again, there is an ischemia reperfusion injury, especially caused by the viscosity, increased viscosity of the blood, and the loss of the autoregulation of the microcirculation that I mentioned earlier in this lecture. On the other hand, the stored red blood cells have increased aggregation function. It's full of pro-inflammatory effect and cytokines. And most importantly, there's a loss of nitric oxide on these red blood cells, and that might cause what they believe a transient mesenteric ischemia right after transfusion, or even during the transfusion. Now, observational, retrospective, report cases, and studies showed an association. However, randomized controlled study showed actually a lower risk of NEC with association with blood transfusion. So who to believe? We still need more data. We are all awaiting for the transfusion of premature trial that I was honored to be part of recruiting for it. I was one of the PI and in our hospital in US recruiting for it. We finished recruiting all babies, for all subjects for this study. We recruited almost, 18 centers. So the 18 center recruited close to 2,000 babies. It's all about liberal versus restricted blood transfusion and the effect of it as a primary effect on death and significant neurodevelopment impairment at 22 to 26 months. As a secondary, there is a multiple morbidity variable that there is a preset actually factors for it. So hopefully it will be powered to see any association. One of them is the NEC. We are waiting for the final publication of this study. Most likely, we're not going to see that before 2023, so in 2 years from now. Okay. So the main question that people ask nowadays, is it really the anemia that actually happen before we give a blood transfusion, or it's actually the blood transfusion associated injury, gut injury, that is cause this association between blood transfusion and NEC. So in JAMA in 2016, there was a nice study about association with red blood transfusion, anemia, and necrotizing enterocolitis in very low birth weight infant. It was a secondary prospective multi-center observational cohort study. It ran from 2010 to 2014. They evaluated 600 babies. The NEC rate was average, which is very nice, because always, please, when you read any study on NEC, look up their incidence rate, because many of these, breast milk and formula and other pharmaceutical kind of studies, when you look deep into the rate of the NEC, you see that they are reducing the NEC, for example, from 18% to 9%. Well, 18% is too much. I mean, there's no center has a rate of 18%, except if it's really bad when it comes to the management of NEC and preventing of NEC. So yes, they reduced by 50% from 18 to 9, but they barely reached the average rate of NEC after the intervention. So just taking that in consideration. Anyway, in this study, the rate was average 7.4, which is very acceptable. They did a multivariable analysis, and based on evaluation of almost like 4,500 measurement of hemoglobin, almost 7 measurements per infant included in this study. They found that red blood cell transfusion in a given week was not related to NEC, almost powered for, almost significant. Rate of NEC was significantly increased among infants with severe anemia defined by hemoglobin less than 8 in a given week compared with those who did not have severe anemia. So again, they found that red blood cell transfusion, it's not associated, as you see the confidence interval, it's 0.1, it's barely associated, related to the NEC. However, they found a strong association between severe anemia, which is hemoglobin less than 8, in the given week before development of NEC, with a confidential interval of 2 to 18 and p-value of 0.001. So in this kind of study, actually, they found that probably the anemia is probably the main cause of this association rather than the blood transfusion. Another study, published just recently, actually, in the last couple of months, the association of severe anemia, red blood cell transfusion, and necrotizing enterocolitis in neonate, and that's published by Song et al. It's a retrospective case control study run from 2012 to 2020. Different birth weight, less than they sorted the babies into like 3 different categories that developed NEC. And what they found actually that, again, they studied the severe anemia within 72 hours. They studied the relation between transfusion within 24 hours, transfusion within 48 hours, and transfusion within 72 hours of the onset of NEC. As you see, the severe anemia within 72 hours of the onset of the NEC, it's associated with a significant increase of NEC, whether it's without the logistic model without covariates, or when they adjusted for having a UVC and PICC line and history of placenta abruption, it's still associated with a significant association. Transfusion within 24 hours as well, or 48 hours, or 72 hours, all associated with NEC, with a p-value of 0.01, 0.006, 0.008. Even when they run it with adjusted for placenta abruption and UVC PICC line central line presence, it's still standing there. So again, which one is more important, the severe anemia or the transfusion? Nobody knows. I mean, again, it's up in the air. We need to look carefully. We need to plan more studies. Hopefully, as I mentioned, the top study might give us an idea about the answer of these questions. So as of now, in conclusion, we don't know. there is association between blood transfusion, but there is also association between severe anemia in the 3 days to 7 days prior to transfusion and the development of NEC. It's just like, because it's part of my research interest, it's been in the last 9 years, it's the CMV and the viral infection in the neonatal intensive care, and probably I can prepare a talk about that, about viral infection in the NICU at some point soon, inshallah. It has been many case report that link CMV infection with NEC. Like in 2019, we published, Benicio Gomez was our medical student along with me and Pablo Sanchez. We published this study about, we went back and we took all surgical pathological samples from the bowel that of babies who developed NEC. In our center, they used to save the sample for up to 7 years. So we went back and we studied all of these samples that we had stored and we did a lot of coloring and PCRs and other ways of identifying CMV on the sample. And we found CMV in 4% of these surgical NEC, although the babies is not reported to have CMV infection. In another study 2 years before our publication, the Omar Stotir actually even published a little bit more what we thought is exaggerated association, but however, again, carrying CMV does not mean having infection. In both in our study or in the previous study. It just means that you have CMV, whether you acquire it from the mother after birth, or it was a congenital asymptomatic infection, which is happen in 98% of the cases. So this association is just, this finding is just an association, does not mean a cause effect, but it's interesting to know that CMV in this study actually was present in almost 40 to 80% of their samples when they run multiple kind of ways, whether it's again coloring or histocystic studies or PCR and other ways of analyzing gut. Okay, moving on to the second part, or probably the third part and last part, preventing NEC from happening. Well, as I said, although we described NEC, we know about NEC over 6 decades, and actually there's some report from the Chinese medicine from over like hundreds and thousands of years about it, about like dying from blue color, abdomen, most likely it's again NEC. Although we know about it for a long time, we still, again, we don't know the pathogenesis, the true pathogenesis behind it. We have really a significant lack of reliable and specific early clinical and laboratory signs and tests to accurately diagnose this disease. We have not achieved any significant improvement in adding any good treatment options for these babies. We are just, we're still treating them in a supportive way. Its morbidity and mortality still very significant. And we all know in US actually, each one case of NEC will add close to 45,000 to 235,000 per case, depends on if it's medical or surgical, and the recovery and the length of stay that it will add, and the, we need a lot of work on that. And there's a lot of work and research going on right now on this topic, but I just want to say, it is very important. Can you guys hear me? Because it's telling me there is some internet interruption from my end. Hello?
الو
وين
هلا دكتور، ما في دقيقة.
يعني هذا السلايد نفسه ولا؟
ايه هذا السلايد نفسه.
طيب خير ان شاء الله. We need a lot of work to hopefully improve our prediction and treatment. Most likely, in order to prevent this significant problem from happening, we need a combination of measurement. It's not going to be one measurement that will have an effect. It will be a combination of multiple measurements. So, antenatal perinatal care. There's many studies on that. Let's talk about two important things. First, antenatal steroid. We all know that it has a very important role in improving multiple morbidities and decrease it and actually preventing from happening. Most recent Cochrane review on that in 2009, we have up to 30 studies, more than 7,000 women and 8,000 babies, a significant decrease in neck with a confidence interval of 0.32 to 0.78. Delayed cord clamping and neck. I think Dr. Al-Husni from US talked about this topic recently. I'm not sure if it was for everybody or just for the neonatology program. But anyway, we have now accumulated many studies as well, six randomized controlled studies, and there is also a significant reduction in neck in those who had delayed cord clamping, 12% versus 20%. Again, just keep in mind these here, the very high incidence reported in the neck, so maybe it's a question mark, but there is a reduction in general, in overall. Number needed to be treated. So if you delayed the clamping of 12 babies, you might be able to prevent one baby from developing neck. Now, in this kind of study on delayed cord clamping, just of note, the all-cause mortality before discharge did not differ between the delayed cord clamping or routine care. I mean, sorry, routine care now is delayed cord clamping versus those who's not following routine care and they are clamping right away. Okay, prolonged NPO. Again, always a question of everyday round. Why you're not feeding the baby? And the answer is just rolling back their eyes and their lips and no answer. Prolonged NPO at birth, more than 3 days in multiple studies has showed that it will increase the neck rate. In this study, for example, the Konikova, they found an increase from 6.3%, those who were fed early in the first 3 days, versus 10% on those who were NPO in the first 3 days of life, or more than 3 days. Also of note, prolonging the NPO status of extreme low birth weight and premature babies will increase your chronic lung disease or bronchopulmonary dysplasia by 4.5 folds. You will increase the retinopathy of prematurity by almost 3 folds, and it will increase the fecal interleukin 8, which is a very important cytokines in pro-inflammatory interleukin. It will increase it in a significant way in the stool of these babies. So another Cochrane study in 2014 for prolonged NPO, almost like 1,100 babies from 9 randomized study. In that Cochrane, again, there was 2 or 3 publications, small publications after the Cochrane, including the one that I just mentioned on top, not included in this Cochrane. But anyway, in this study, in this Cochrane review, they found that there is no difference on neck. In general, there's no difference in all-cause deaths in prolonging the NPO, but prolonging NPO on these babies, it caused a delay in establishing the full feed by almost 2 to 4 days, and same result was happening between the IUGR babies. So even in the Cochrane, if there is no effect, you are delaying the full feed by 2 to 4 times. And that by itself has a lot of effect, including increase the length of stay, increase the morbidity from having central line, etc. But however, again, as I said, this Cochrane from 2014 needs to be updated because there is a couple studies after that that showed actually a positive association between prolonged NPO and neck. To me, I will not suggest to have MPO status more than 3 days. I usually wait maximum 24 hours, but my default is to feed the baby unless you have a contraindication. It's not the other way around. So always I ask why you're not feeding as a question rather than can we feed or not. Standardized feeding protocol. I think, again, Dr. Al-Hosni is talking to multiple doctors inside Syria about standardizing the feeding protocol. In general, any kind of standard feeding protocol that you will carry in your unit will improve your outcome. Many studies, they showed the same outcome. Now, whether you start trophic feed 5 to 7 days and then you go up by 15 to 20 milli per kilo per day, that will have a significant decrease in neck and overall mortality. Whether you trophic feed for 6 to 8 days and then up by 20 ml, again, you will decrease the TBN, the need for TBN days on average 15 days and reach full feed almost 11 to 13 days faster, and a significant decrease in neck and late onset sepsis. So it's all good. Just need to have a standardized feeding protocol that will implement an early introduction of feed as a trophic feed, and then an increase in a specific way, whether it's a specific amount per kilo or a specific amount of mLs per day. You pick and choose. There is multiple protocols out there that you can borrow and implement. Breast milk and mother's own milk, mom. We all know that it's very important. There is a lot of benefits in it. We all know about it. I don't have to mention all of that, but it matures the gut. It will mature the mucosal barrier. It will enrich the flora with the beneficial bacteria, etc. Knowing that freezing and thawing actually the breast milk might affect these components and might decrease these protective effect. So when it comes to mother-owned milk or the human donor milk, should we feed this or that? The benefit of it in general, these studies will summarize that. Again, any very low birth weight in KIMAC 2015, any baby who received less than 7 days of exclusive breast milk in the first month of life will have an increase of risk of neck by 4-fold. That's again point out the importance of increasing the breast milk feeding in our unit. Again, in 2009, the Mehند there found that neck or death after 2 weeks will decrease by a factor of 0.83, almost 80%, for each 10% increase in the mother-owned milk in total intake. So every 10% increase in mom milk will decrease the neck by a factor of almost 1. You go by 20%, you decrease by 2, etc. So again, that's the importance of the milk. Cochrane in 2019, they compared the human donor milk to formula. They found 12 trials, almost 2,000 babies. And as we mentioned before, formula was found to increase the risk of neck. Formula-fed infant as well had, however, better weight gain, linear, and head growth. So we need to take in consideration the calories that we're giving these babies. And probably most of those babies who are receiving breast milk and human donor milk will need some kind of supplementation. Now, when it comes to supplementation, most of the supplementation we have, it's cow-based milk. And that will take us to the second part of this topic, which is feeding conclusive mom-owned milk or human donor milk. This study from 2016, it focused on feeding exclusive human milk-based diet. What we mean by exclusive, that means even when we supplement the mother milk with human milk fortifier, HMF, this will be also a human-based or derived, human milk-derived fortifier. So they compare those babies who are receiving any kind of bovine-based milk, whether it's formula or a mother-owned milk fortified with bovine fortifier were compared to those babies who was fed exclusive human milk. That's mean either mom milk or human donor milk with or without a human milk derived fortifier. So no cow-based milk at all in their diet. They almost had 1,500 babies or 1,600 babies. There was no difference in the baseline demographic growth between the two groups. And when it comes to the result, they found that those babies who are fed exclusive breast milk in the gray has always all kind of neck decreased in a significant way, whether it's all neck, medical neck, surgical neck, and even mortality was significantly decreased in those babies who are fed exclusive breast milk. When it comes to gestational age as well, they found a significant decrease in the neck across the board of gestational age. And when it comes to outcome in general, they found that, again, less onset infection, much more decreased in those who are fed exclusive breast milk. No difference in IVH because it's multifactorial. Ventilator is less days on ventilator, as well as retinopathy of prematurity, much less. Patent ductus arteriosus requiring treatment, and bronchopulmonary dysplasia as well, all were decreased in those babies who are on exclusive breast milk diet. The other question that we have always, should we slow advance the feed or be more aggressive? To answer this question, there have been many articles published and many review as well published. The most recent one is from just last month in 2021, when they compared the slow advancement of milk defined as 15 to 24 milli per kilo per day versus faster advancement of 30 to 40 milli, so almost double the amount. They found 14 randomized control study, 4,000 babies. However, 2,800 babies come from one large trial, which is good and bad. Slow advancement probably they found that has a little or no effect on neck. So it is not gonna make a big difference on the rate of neck. Slightly increased feed intolerance, the slow advancement. It's not the quick, actually, so it's worse. Slightly increased risk of invasive infection. So in general, they found that in these Cochrane, actually, the fast advancement of 30 to 40 might be more beneficial than what we practice right now in most of the unit of what we call regular advancement, but here in this Cochrane was called slow advancement of 15 to 24 milli per kilo per day. Withholding feeding during packed red blood cell transfusion is another question that we all get asked about it on daily basis. LDEEP in 2011 looked at this issue, and they found that withholding feed during transfusion associated with a decrease of neck. And that's opened up the door to more studies to be published on this topic. Again, in 2014, Marine found that feeding during packed red blood cell transfusion was associated with a decline in the postprandial mesenteric oxygenation for up to 15 hours. So those who were fed during the transfusion, they will have a transient mesenteric oxemia for up to 15 hours after the transfusion compared to those who were not fed during the transfusion. And that might play a role in the development of neck as well. Gisani in 2017 did a meta-analysis. They found a 7 non-randomized controlled study. Please pay attention. It's a non-randomized controlled study, 7,000 babies. They found a very different approaches to the withholding from 4 hours before, during the transfusion and after, to 3 hours before and 9 hours after, to 12 hours around the transfusion, up to 24 hours during and after packed red blood cell transfusion. In general, they found that withholding feeding significantly reduced the incidence of the TANIC or the transfusion-associated NEC with a p-value. But again, there was a very variant approach. So it was not homogeneous studies to start with. And then all the studies was a non-randomized control study, unfortunately. So what do we need? We need randomized control studies to be done on this topic before we confidentially support this kind of approach or encourage it. So as of now, feeding or not feeding during transfusion, it's up to the unit and what they decide about their approach of NEC prevention bundle that they have in their unit. Again, continuous or intermittent bolus feeding. Another question that we will be asked about it, and whether we, for extreme low birth weight, whether continuous is better or intermittent better. From June of this year, just again 3 months ago, there was a review on that, a Cochrane review. There was a 9 randomized control study, 900 babies. Certainty of evidence was low to very low. Just keep that in mind. Continuous feeding actually reached full feed almost 1 day later. So intermittent was more beneficial than continuous when it comes to reaching full feed. But they did not find any difference in number of days to regain birth weight, days of feeding interruption, and rate of weight gain. They found a little to no difference in length of head circumference gain, and there is no effect on risk of necrotizing enterocolitis. So there is no difference in this kind of review with a very low to evidence, certainty of evidence. There was no difference in the rate of NEC. However, we know that intermittent feeding in general is more physiologic to the babies. It will help mature the bowel in a better way. It will help regularize the enzyme production, and it will help actually reaching full feed faster than continuous feed. So again, in general, there is no difference between them. Whether to do it or not, it's up to the unit and up to the consultant. In general, we don't encourage continuous feed in extreme low birth weight. That's at least what I practice and what I used to practice in multiple hospitals. The probiotics is a very, very hot topic that has gained a lot of heat in the last few years. To summarize, like how much kind of interest that people has in it, this Cochrane review from last year, October last year, they found 56 trials. Most of them are small, but in general, we have 10,800 babies included in these studies. In most of these studies, unfortunately, the methods were not clear when it comes to the blindness, whether the doctors and the staff knows if they are giving probiotics or not. The variation in formulation of probiotics, whether it's a one bacteria or multiple bacteria, what's the dose, how often and for how long you give it, was very variant and different from study to others. But in general, again, they found that probiotics may reduce the NEC in a significant way, but you need to treat 33 babies to prevent one case of NEC. Mortality as well might be reduced, but again, you need to treat 50 babies with probiotics to reduce a possible one case of death. And late onset invasive infection also might be reduced. Also, you need to treat 50 babies with the probiotics in order to prevent one infection from happening. So in general, as a summary, it's very promising, but we still need a little bit more randomized, a little bit more consistent studies, more standardized way of using these probiotics. We still don't know exactly what type of bacteria we should use, what's the dose of these bacteria, what's the timing, how long we need to treat in order to, again, encourage and support this kind of practice. So as of now, again, it's different from unit to unit. based on their bundle and what they feel more important for their babies when it comes to these strategies. Antibiotic stewardship, very important topic for the inside in Syria. It will improve the outcome of the extreme low birth weight from many aspects. Again, in 2011, there was a retrospective study, 2-to-1 control case analysis comparing neonates with NEC to those without NEC from 2000 to 2008. They found 124 cases of NEC matched with 248 infant without NEC. After removing subject with proved sepsis, exposure for more than 10 days of antibiotics resulted in a threefold, 300% increase in risk of developing NEC. That's again point out the importance of reducing and be wise when you use the antibiotics in premature babies and in term babies as well. Capella in 2011, again, another study, 365 infants less than 32 weeks. They found that prolonged initial empirical antibiotics more than 5 days without approved infection was independently associated with increased length of stay, NEC, and death, and it was all significant p-values and confidential interval. Again, in general, antibiotics overall, when it's needed, is very important to be used. When we overuse it, it's very harmful, and we need to be very careful with it as well. Anti-reflux medication, another medicine that it's mostly prescribed by wrong way in our neonates for apnea bradycardia desats episode, although the association of apnea brady desats and reflux in general is very poor. Many studies showed a poor association. In Fiore in 2010, they found that only 3% of these episodes associated with reflux. In another study in Nobel et al. In 2019, they found 11% association. There was a little bit more physiologic studies when they study exactly the timing of the reflux and the apnea and desats. They found that most of the cases, actually, the reflux is following the apnea, desats, bradycardia. It does not precede it. It does not come before. It comes after. So anyway, in 2003, we have a very nice meta-analysis about inhibitors of gastric acid, as they call it in that study, the IgA, and NEC. They found one case control and one prospective cohort study, almost 11,000 baby. And they found an increase, a significant increase in NEC in those who were treated with anti-acid medication, or what they called inhibitor of gastric acid. That's in a very significant way. The confidential interval was very tight and the p-value was very significant. Also, on the other hand, they found a significant increase in infection, whether it's sepsis or pneumonia or UTI, all across the board. There was an increase in infection in those babies who are on inhibitors of gastric acid. As a very significant number, a scary number, 37% in these babies had infection, comparing to almost 10% for those babies who are not on anti-reflux medicine. Very significant data that should open up our eyes to it. And my recommendation always, routine use of anti-acid medicine should be stopped. And those who work with me know me very well. On my very day of any service, I stop almost 90% of anti-acid medication on my babies. Again, if there is no proof of use or indication for it. In US, we use not to start any single baby. We don't start them on anti-acid till we study the reflux in a very objective way. Upper GI is useless when it comes to studying reflux and prove there's reflux. 90% of the babies will have reflux on upper GI. It's useless test to do. We used to do the probe. We used to do the acid probe and the, what we call it, the other probe that measure the pressures inside the esophagus, and we'll compare the acid and the presence of reflux to the signs and symptoms that the baby have. We have a sitter, a nurse who will sit with the baby for 24 hours while we have the the impedance study and the pH study. We have a nurse who are reporting to us the symptoms and the signs, and then we compare whether there's an acid, a true acid in the reflux and symptoms, and then in the end we have a score. If it's more than 3, that means it's significant. Whoever has less than 3, we don't recommend anti-acid medicine, even though for these babies who are recommended to have anti-acid medication, we give them a trial of 2 weeks to 3 weeks maximum. If there's no improvement in the symptoms, we stop it right away. Lactoferrin and prebiotics, there was a lot of talk about it in the last few years, and it gained a lot of heat as well. Both of these two things start to lose their importance, although there is some studies that showed it might be promising, but it was all initial report, case reports, stuff like that. In the Cochrane review of the lactoferrin and NEC 12 randomized control study, again, that will tell you how important the topic was for these people. They found a decrease in late onset sepsis and length of stay, no change in the NEC or all-cause mortality, decrease in the NEC when combined with probiotics. So again, lactoferrin by itself was not that important in decreasing the NEC. When it was associated with probiotics, there was a decrease, but whether it's the probiotic or the lactoferrin or both, we need more studies on that. The other thing that the prebiotics as well, which is the undigested poly and oligosaccharides that are found in the breast milk of the mothers. There was many studies on it as well, and they found a significant decrease initially, but later on, these benefits start to fade away in many studies, and they found actually a lot of side effects from using the prebiotics. The thing that about prebiotics, just briefly, because I think we'll finish after this one, the prebiotics is like a fingerprint. Actually, if you study the prebiotics, the oligo and polysaccharide, the undigested in the breast milk of the mom, you will be amazed how it is very unique for each mother to have a specific algorithm and a specific amount and map of distribution of these polysaccharides. So it's different from mother to mother, and that will make a sense that when we feed the babies the mom own milk, we will see many, many benefits that we don't see when we feed them donor breast milk or milk from other mothers. That might be actually related in a special way to the prebiotics that is significant and found in each breast milk in a unique way, different from other mothers. Conclusion, again, there's no one definition for NEC. Unfortunately, there's a lot of medical entities that are grouped together in the diagnosis of NEC. The development of clear definition will be needed because that's what will help us advancing our research and diagnostic and prevention as well as treatment effort. GI tract immaturity, intestinal inflammation, and dysbiosis are very important pathophysiologic component of classic NEC. No reliable markers of early stages of this disease available right now. There's no marks to predict when this NEC will happen. And treatment options is very limited right now. It's just supportive and standard feeding protocol using breast milk have been shown to decrease the incidence of NEC. Probably that's the only proved approach right now, along with antenatal care using antenatal steroid. These are the two things that will help us reduce the incidence of NEC. Thank you so much for your patience and listening to this lecture. The floor now is open for any questions that you will have in Arabic or in English. Thank you so much.
جزاكم الله خيرا دكتور مهند for this amazing presentation.
الله يعطيكم العافية. طيب, I think 1 hour deserve at least 10 questions. يلا بسم الله.
في يمكن سؤال أو أظن حليب الأم ليس هناك أي نظر للكمية أو فترات زمنية محددة للإرضاع خاصة القصيرة.
حليب الأم ليس هناك أي نظر للكمية أو فترات زمنية. ما فهمت السؤال يعني. راح جاوب حسب ما فهمته. بالإجمال it's very important to start the first feeding as a breast milk. It's very important. So that's why in many units, including our unit for extreme low birth weight, we hold the feeding for 24 hours waiting for breast milk. If we have breast milk, we start. If we don't have, we don't start for 24 hours. And then we consider starting formula and other options. الكمية as we said مثل ما حكينا من قبل الكمية عفوا راح جاوب بالعربي. بالنسبة للإرضاع الأول أول رضعة مهم جدا تكون حليب الأم. في فوائد كثيرة لأول رضعة إنه تكون حليب الأم. ونحن الوحدة تبعيتنا وبكثير وحدات بالعالم بيستنوا أول 24 ساعة على التغذية لإكستريم لو بيرث ويت بيبيز لحتى يلاقوا حليب الأم. إذا ما لقوا حليب الأم بعد ب 24 ساعة وحتى في منهم بيستنوا 48 ساعة ببلشوا بالحليب الصناعي أو المواد الثانية. بالنسبة للكمية نعم يوجد فائدة لزيادة الكمية بالحليب الكامل اللي عم ياخذه الطفل. مثل ما ذكرت بالمحاضرة تبعيتي كل زيادة 10% من الإجمالي للتغذية الطفل راح تنقص احتمال حدوث التهاب الأمعاء التنخري بمعدل 0.8 كفاكتور. فكل 10% بتنقصه تقريبا واحد يعني بمعدل 1% أو 10% أو so. It is very difficult object in Arabic. How about English? والله مزبوط يا أحمد. Very important. That's will point out the importance of learning English يا أحمد. السلام عليكم. بعد إذنك حكيم بس استخدام مضادات الحموضة واستخدام في حالة النك. طيب نحن طبعا ذكرت أنا هالشيء هذا بالمحاضرة. استخدام مضادات الحموضة تزيد معدل حدوث التهاب الأمعاء التنخري وهي مضاد استطباب قطعي ولا يجب استخدامه أبدا أثناء التهاب الأمعاء التنخري لأنها تزيد الطين بلة وتزيد الإنذار سوءا. كمان هي بتزيد احتمال حدوث الالتهابات الانفكشن. الالتهابات بشكل عام تزيد احتمالها عند الأطفال اللي محطوطين على مضاد الحموضة. لذلك استخدام مضاد الحموضة يجب أن يتوقف تماما عند حديثي الولادة إلا إذا عندك دليل واضح إنه الريفلكس أو الارتجاع اللي عم يصير عند الطفل هو حمضي وهو يسبب أعراض للطفل وأعراض مميزة. دراسة المادة الظليلة للأمعاء الأبر جي آي هذا اللي بنعمله ليس فحص دقيق لتشخيص القلص المعدي لأنه معظم الأطفال بده يكون عندهم قلص معدي بالدراسة الظليلة. طيب الله يعطيك العافية أخي أحمد السعود. إذا ممكن شرح بروتوكول تغذية بالعربي. طيب البروتوكولات بالإجمال تتمحور حول شغلتين بشكل أساسي. أول شغلة بداية الابتداء بالتغذية باكرا خلال أول 24-48 ساعة بما يسمى التغذية التروفيك فيد. التغذية يعني أو التغذية الفموية القليلة عادة أقل من 20 ملي على الكيلو باليوم للطفل. هذا اللي نبلش فيه كتغذية مبدئية عند الأطفال. تتراوح هي الفترة بين 3 أيام ل7 أيام. هي التغذية مهمة جدا للأطفال لحتى نجهزهم لزياده تدريجيه للحليب الام للحليب التغذيه بعد هالفتره هي، بعد اول 5 ايام او 6 ايام او 7 ايام حسب البروتوكول اللي راح تتبعه انت. فهذه التغذيه الفمويه القليله اللي هي احيانا بتكون ملي او مليين على كل ساعتين تستمر 5 ايام، بعدين بتزيد التغذيه بمعدل بين 15 ملي على الكيلو على اليوم الى 40 ملي على الكيلو على اليوم. ما في فرق بين الزياده البطيئه او الزياده السريعه بمعدل الالتهاب الامعاء التنخري او المشاكل الاخرى. فباختصار هو عباره عن جزئين، اول جزء تغذيه تمهيديه لمده 5 إلى 7 أيام تبدا خلال اول يومين من الولاده. طبعا اذا ما في مضاد استطباب واضح مثل مثلا نقص ضغط شديد والله محطوط على دوبامين دوبيتامين ابنفرين، لا شيء ثاني. اطفال مستقرين على اكسجين خفيف يعني 30 40% واقل، هذول الاطفال غالبا يمكن تغذيتهم خلال اول يومين من الولاده تغذيه تمهيديه لمده 5 إلى 7 أيام بمعدل تقريبا 20 ماكسيموم 30 ملي على الكيلو باليوم. بعد ذلك نبدا الزياده التدريجيه بمعدل 15 الى 30 ملي على الكيلو باليوم كل يوم. ذكرت باول محاضره انه مرض الخداجه فهل ممكن نشوفه عند تاميل حمل؟ نعم يمكن نشوفه عند تاميل حمل. اهلا وسهلا دكتوره نجوان من زمان. نعم ممكن نشوفه عند تاميل حمل، ولكن بحالات خاصة. معظم تام الحمل اللي بيطوروا نيك بيكون معهم مشاكل أخرى، بشكل أساسي مشاكل قلبية congenital heart defect، يعني مشاكل مزرقة قلبية مزرقة. المشكلة الثانية اللي بنشوفها نقص الأكسجة حول الولادة سبب أساسي للنك. والمشكلة الثالثة اللي هي قليلة جدا مشاكل تشريحية بالتروية الميزنتريك يعني المعائية. بس معدل حدوثه عند تام الحمل تقريبا أقل من 1%. أي سؤال ثاني يا شباب؟ هي 1 2 3 4 5 أنا ماشي حال 5. كان في كلام عن علاج PDA والنك، البروفين دور وقائي والاندوميتاسين مؤهب. نعم حسب الدراسات، يعني الدراسة اللي أنا عرضت لك إياها حاطين إنه الاندوسين يترافق مع زيادة حدوث النك، والآيبوبروفين يترافق مع نقص حدوث النك. الشيء الأساسي اللي يعني من عند الميكانيكال اوف الفارماكينيتكس، الاندوميتاسين نعرف انه هو فيزو بريسر يعني مضيق وعائي، بيأثر على الكلية، على وظائف الكلية بشكل عام، ويؤثر على الأمعاء كمان. الآيبوبروفين تأثيره أقل وقت اللي بيصير بقى هالموضوع هي. فالبي دي اي اذا كانت مهمه وكبيره وعم تعمل سرقه للدم، بمعنى انه بالطور الانبساطي عم يصير عوده عوض ما الدم يكفي يعني يكفي السيركل العاديه، عم يصير ارتجاع بالابهر بسبب البي دي اي. فهذا البي دي اي هي بجوز تسبب كمان نقص ترويه يعني للامعاء. فعلاجه قد يكون موضوع وقائي، قد انا ما عندي دراسات عم بحكي بشكل نظري، ولكن كيف نعالجه هو هذا السؤال. فهون وقت اللي عالجوه بالاندوسين شافوا انه في زياده، وقت اللي عالجوه بالايبوبروفين كان في حمايه. طيب الله يجزيكم الخير، يعطيكم العافيه. في اي سؤال ثاني يا جماعه؟ ممكن ملخص عن علاقه نقل الدم. طيب الدراسات اللي اوضحت غريب مع انه كنت كثير يعني بطيء بالحكي. طيب الدراسات اللي اوضحت وجود ترافق بين نقل الدم وحدوث النك معظمها دراسات رجعيه وليست راندومايز كنترول ستدي، يعني ليست ما بعرف شو تفسيرها بصراحه. بس الدراسات كانت يا اما ريبورتس، يعني انه والله الدكاتره عم يعملوا والله حالات قليله بيعملوا لها ريبورتنج انه والله صار في اسوسيشن، يا اما دراسات رجعيه وليست مستقبليه. وقت اللي عملوا دراسات مستقبليه وجدوا عدم وجود علاقه بين نقل الدم وبين حدوث النك. بالعكس في دراسات، في دراسين او 3 اظهرت انه معدل حدوث النك اقل عندما ننقل الدم لهذه الاطفال. طيب بالنسبة لفقر الدم كمان في دراسات وقت اللي درسوا حدوث وجود فقر دم شديد اللي هو أقل من هيموغلوبين أقل من 8 ملغ على الديسيليتر، وقت اللي درسوا وجود هذا فقر الدم الشديد خلال الأسبوع الذي يسبق نقل الدم أو 3 أيام التي تسبق نقل الدم. بمعنى نحن عم نخلي الولد ينقص الهيموغلوبين عنده، ينقص لحتى يصير معدله 7 أو 6 لنعطيه دم. ما عم نعطي دم بمعدل وقت لي والله بينقص تحت 10 أو على 9. عم يصير مع الولد فقر دم شديد أقل من 8 قبل ما ننقل الدم. وجدوا إنه الأطفال اللي عندهم فقر دم شديد أقل من 8 خلال 3 أيام أو 7 أيام من نقل الدم، هدول الأطفال تترافق النك معهم أكثر من الأطفال اللي ما عندهم فقر دم شديد، اللي كان نقل الدم حادث بعد فقر دم خفيف، يعني مثلا هيموغلوبين 9 أو 10 عم نعطيهم دم، مقارنة مع هدول اللي فقر الدم عندهم شديد 7 و8 و6. هدول اللي عندهم فقر دم شديد عم يصير معهم نك أكثر من الأطفال اللي عندهم فقر دم خفيف قبل نقل الدم. عرفت علي شلون أخي ناصر؟ بالعموم لحد الآن نحتاج إلى دراسات أكبر وأوسع لنثبت هذه العلاقة. في دراسة هلأ تمت في أمريكا اسمها Transfusion of Prematurity، نقل الدم عند الخدج. خلصت هلأ يعني غلقت، بس عم يستنوا النتائج بعد 2 تطلع. فغالبا إن شاء الله هاي الدراسة ممكن تعطينا جواب لهالسؤال المهم اللي طرحته حضرتك. نفس الشيء وقت اللي بيجي لعلاقة التغذية أثناء نقل الدم بالنك، في كتير ريبورتس يعني كيسز عم يصير لها بابليكيشن. ما في دراسات مستقبلية، كلها دراسات رجعية أثبتت وجود علاقة بين تغذية الطفل أثناء نقل الدم وحدوث النك. ليش؟ في دراسات أثبتت أنه إذا غذيت الطفل أثناء نقل الدم يحدث عند هدول الأطفال نقص أكسجة مؤقت في التروية المعوية لمدة 15 ساعة بعد نقل الدم، مقارنة مع الأطفال اللي ما كانوا عم يتغذوا أثناء نقل الدم. ف يعني هاي الدراسة ممكن تقول لك إنه والله عم يصير نقص أكسجة وبجوز سبب نك. الدراسات الثانية كمان أظهرت إنه إيقاف التغذية أثناء نقل الدم أو 3 ساعات قبل و9 ساعات بعد أو 12 ساعة بعد أو 24 ساعة بعد نقل الدم، كلياتها كانت مترافقة مع نقص معدل حدوث النك. بس كمان هي الدراسات كلياتها دراسات رجعية وليست مستقبلية، وليست يعني بروسبكتيف. فنحتاج لدراسات واضحة وتكون راندومايز، تكون عشوائية، فيها فصل بين الحالتين، فيها وضوح تماما بالبروتوكول وشلون عم نغذي وشلون عم نوقف وايمتى عم نوقف لحتى نثبت هالعلاقه هي. فمشان هيك العلاقه التغذيه اثناء نقل الدم هلا حاليا كل يونت تتبع اسلوب معين. كل يونت، نحن مثلا هلا اليونت تبعيتنا الحاليه نحن ما بنغذي الطفل اثناء نقل الدم، بنعمل نقل الدم بين التغذيه، يعني بياكل الولد نستنى ساعة نعمل نقل دم، بعدين بنغذي التغذية الثانية بتأخير معدل ساعة إلى ساعتين. المشفى اللي اجيت منه بأمريكا كنا ما نغذي الطفل أثناء نقل الدم وما نغير تغذية الطفل باليوم اللي بننقل له الدم، يعني لا بنزيد كمية التغذية ولا بنزيد فورتيفيكيشن، ما بنزيد سبلمنت، يعني ما بنحط مثلا مغذي جديد أو فيتامين د أو حديد لمدة 24 ساعة، ونوقف التغذية 3 ساعات قبل وساعتين بعد. فهذا كان أسلوبنا هناك. وهلأ أسلوبنا الحالي هون بالسعودية إنه لا نغذي أثناء نبلش نقل الدم ساعة بعد التغذية ونوقف لمدة 3 ساعات، فبصير في تأخير بالتغذية الثانية لمدة ساعة أو ساعتين. حاليا نتعامل مع فقر الدم ونقل الدم مثل قبل، يعني لا جديد عمليا. نعم لا جديد عمليا. أهلا وسهلا. غيره يا شباب؟ في أسئلة من متدربي النيونيتال انتنسيف كير. أي سؤال يا شباب؟
تمام حكيم، الله يجزيك خير. من ناحيتي ما في شيء، الله يكرمك إن شاء الله.
أهلا وسهلا. طيب مستقبلا يا شباب، أنا يعني هو بالنهاية نحن يعني الغاية هو الفائدة إن شاء الله. أنا بعرف إن راح تفضلوا الكلام بالعربي، بس في حل وسط مثلا، هل نعمل سلايدات أجنبي ونحكي عربي، ولا نص نص، ولا يعني ما بعرف شو رأيكم؟ بجوز ممكن الدكتور عدنان أو الأخت اللي عم تعمل المودريتنج هون مثل تعمل استطلاع رأي سريع ونشوف شو الأنسب يعني بين الخيارات المطروحة.
احنا عملنا دكتور قبل هالمرة استطلاع رأي استبيان عن يعني اللغة اللي بيفضلوها. تقريبا معظمهم كانوا مع اللغة الإنجليزية، بس إنه لسه مثل ما حضرتكم تفضلتوا إنه في كمان ناس إنه لا حابين يكون فيها بالعربي، بس حسب الاستبيان كان المعظم كانوا مفضلين إنه يكون في لغة إنجليزية.
هي والله فرصة ترى، يعني أنا مو مشان شيء، بس هي فرصة إنكم تسمعوا اللغة الإنجليزية، فرصة إنه تشوفوا شلون البرزنتيشن بصير بالإنجليزي، سلايدات ترتيبهم كذا، يعني لغة ثانية، وطبعا هي يعني لغة التواصل حاليا يعني يعني بركي بصير في تحريض او يعني انكورجمنت او تشجيع يعني على تعلم اللغه، لانه بالنهايه يعني حبينا ولا ما حبينا هي لغه العصر يعني ولغه الطب، فمهم جدا يعني تشتغلوا على حالكم، وان شاء الله يعني بزياده جهد بزياده تعب شوي بركي ان شاء الله بيتحسن يعني. فترة 10 ثواني. طيب بجوز والله كنت سريع شوية يعني، لا تأخذوني. نقل مباشر. طيب خلاص، الله يجزيكم الخير. إذا ما في أي سؤال ثاني الله يعطيكم العافية وشكرا للاستماع وجزاكم الله خير. السلام عليكم، الله يوفقكم جميعا وييسركم أموركم يا رب. السلام عليكم.
وعليكم السلام.
عليكم السلام ورحمة الله.